Hi, I'm Bob Timmerman. I've been asked to give an overview of the special relationship UT Southwestern Department of Radiation Oncology has had with the treatment that we now call SAbR. This SAbR treatment, which stands for stereotactic ablative radiotherapy, is now over 20 years old. The early work that was done in the 1990s, including the spine treatments done in the United States, originally with rigid immobilization by Hamilton and colleagues. Professors Ingmar Laux and Heinrich Blomgren worked together at the Karolinska Hospital, which was also the home of the Gamma Knife, to create a new stereotactic body frame, and did some early treatments in particularly liver metastasis and hepatoma. Simultaneously, researchers in Japan did some of the early lung treatments and reached a broader understanding of lung motion for treating lung cancer. And our own UT Southwestern researchers carried out the first formal clinical trials in SAbR, as well as some early work in the late 1990s. And the treatment early on included multiple beam treatments, this one again in a body frame with abdominal compression showing by that paddle. But the tumor was surrounded or enveloped by a high dose, this time shown purple, and the yellowish target then would be treated in a very small volume of high dose with rapid fall off to normal tissue. In our work, we published early NIH-funded clinical trials. In the early days, we didn't have a dose for this treatment, and so we carried out classic phase 1 designs where you start out at a low dose, a dose that by today's standards wouldn't be considered very potent at all, 8 gray times 3, but systematically work up to higher doses with delayed periods in between to observe for toxicity. We did 3 separate tumor size categories, small, medium, and large tumors in primary early stage lung cancer. We chose that clinical model because these patients both needed a better treatment and would potentially live long enough to see the toxicity of the treatment, which may not be true of treating metastasis. So you treat a group of patients, then you compare their changes in, for example, pulmonary function compared to what it was at baseline. And to our surprise, we escalated to really, really high doses, higher doses than had ever been used in the field of radiation oncology. And what we found was if you plotted out patients treated at different dose levels, bin them out, and in this case to low, medium, and high dose ranges, that the tumor eradication rate was dramatically higher at the highest doses. And that let us be able to plot out what's called a sigmoid dose response, in this case, plotting Fourier local control against the dose that was used in the treatment. What you can see is that we were able to reach very high rates of local control with the higher doses. And in fact, sigmoid dose response has a plateau at the top where increasing the dose doesn't help beyond a certain area, and we reached that efficacy plateau. But importantly, this is the toxicity curve, and the toxicity curve, even at the higher doses, was still below the magic 33% range that's used in phase 1 designs. In other words, at a dose even below the maximum tolerated dose, we had a very wide therapeutic window, and this was something that honestly we had not seen in using radiotherapy as the primary treatment against the majority of cancers. And of all the cancers to do this in, one of the most resistant cancers and most deadly cancers, which is lung cancer. So what should we call this new therapy? In our first paper that we published early on, and we called it extracranial stereotactic radioablation, or ESR. It was a good name because it was descriptive, but it didn't work out for political reasons when we tried to get billing codes. The administrators at ASTRO, the society that helps promote radiation oncology, named it stereotactic body radiation therapy. This name was neither catchy nor very descriptive, but that name is still around today, and in fact is assigned to the billing code. But later on, a Stanford researcher, Billy Liu, came up with the name stereotactic ablative radiotherapy. This is a much better name because it's descriptive. It has the ablation word in it. And it also has the catchy acronym for a sword, like a saber. And that's the name that we've encouraged using in our more recent publications. I described before a sigmoid dose response curve for early stage lung cancer treated with SAbR. And there's other dose responses that can occur besides just local tumor control. For DNA damage, we know that even doses as low as 2 gray will affect the tumor's ability to repopulate. So DNA damage occurs at doses of even below 2 gray. But you can imagine there are many effects that could occur that won't first happen unless you're at a fairly significant dose. And if you don't give a significant dose, you wouldn't see these so-called threshold effects. And there are many of them. Dr. Hallahan showed that blood vessel density undergoes apoptosis at doses first starting at 16 gray. In other words, if you use 2 gray, you wouldn't see these effects. And Dr. Kolesnik and Fuchs showed another vascular injury pathway in the ceramide pathways that first is noticed at 10 gray. And some of the immune effects that may be induced by radiotherapy won't happen until you get doses around 15 gray, as shown by Drs. Few and Wexelbaum at the University of Chicago. The point is, if you give 2 gray, you wouldn't see any of these effects. And so these become opportunities to use a therapy in a way that might be more effective. They're basically degrees of freedom. In terms of SAbR and milestones at UT Southwestern, as I mentioned, we started treating primary lung cancer, but we did additional studies in metastasis. We used very formal testing, often funded by grants. And one of the most exciting things was that the clinical results that started with our researchers ended up creating a new standard of care for early stage lung cancer. New standards of care don't happen very often, so this was indeed a big deal, where SAbR now is the standard of care for medically inoperable patients with early stage lung cancer. And clinical trials in lung, liver, and spine metastasis were also carried out. In prostate cancer, we got a DoD grant to try to help people from rural, mountain, and military assignment, where it's not easy for them to come in for multiple treatments. And along with others' work, that prostate cancer work resulted in a new billing code, and SAbR is now the fastest growing treatment for early stage prostate cancer or intermediate risk prostate cancer. Then our department started to focus more on metastasis, and in particular, we were trying to exploit some of the strengths of the institution. We have a very strong kidney cancer program led by Jim Brugarolas and others, and we've been using SAbR as initial treatment in a subset of patients with metastatic kidney cancer, and also have clinical trials for earlier stages of kidney cancer. In breast cancer, we've expended a fair amount of resources to try to do focused rather than whole breast treatments, including using the CyberKnife to treat early stage breast cancer, and invested in one of the first technologies to do focused gamma knife-like treatments for breast cancer, the Gamma Pod, which is available at our center, and we're running clinical trials for that as well. And then we have a number of boutique type therapy trials in early stage larynx cancer, tumor thrombus, and others. But the bottom line is a lot of activity has occurred at UT Southwestern in the realm of stereotactic ablative radiotherapy. But what's next to come? What's hot right now in fractionated radiotherapy is a concept called adaptation. And there are a number of opportunities to buy new machines to try to carry out these adaptive processes. including MR-Linacs and CT-Linacs that can replan on the fly. Adaptation is, by definition in radiotherapy, is responding to change, or in the case of new information. And most often that change relates to a shrinking tumor. That is, a tumor that was big, you treat it, and hopefully it's going to get small. In this particular picture, which shows a tumor shrinking, the target actually ends up extending outside the patient's body, and so would warrant a replanning of that treatment. The obvious Achilles heel, though, of adaptive radiotherapy, in particular using conventionally fractionated radiotherapy, is that with conventional radiotherapy, there's really little change to adapt to. In fact, conventional radiotherapy is all about not causing too much of a stir. It's these small, tiny little daily doses that nudge the tumor more than it does the normal tissues. And so there really are very few significant changes to adapt to. To give you an example of what I'm talking about, if you wanted a lot of change, the conventional radiotherapy is more like Jennifer Aniston. Here she is at age 20, and then at age 50, not a whole lot to adapt to. What you'd rather have is a change like Mick Jagger. Mick Jagger lived a much harder life. Here he was at age 20, and here he's at age 50. And that big change that you see would be much more opportunity for adaptation. Now, split coursing a SAbR, that is separating a SAbR treatment by a longer amount of time, intentionally increasing the time between changes, constitute an opportunity to adapt that is far greater than what we'd see with conventional radiotherapy. For example, there's nothing that would make a tumor shrink more than SAbR. In terms of a radiotherapy treatment. It has the highest early response rates of any form of radiotherapy. And so if we just let the tumor shrink and not get on with the next treatment right away, we would see a lot of opportunity. And other tumor features will change as well. The term ablative means it's going to disrupt the function of the tissue that's treated. And so that disruption of function, that is the change in the function, could be very useful. The tumors after treatments like SAbR will express new markers. PD-L1 negative tumors will become PD-L1 positive, for example. New genes will be expressed, degrees of apoptosis. Literally the degree of explosion from the treatment of these cells could expose a lot of DNA. And that, therefore, not only the tumor, but the microenvironment around the tumor will change. It will become more or less oxygenated. Different cytokines will be floating around, and the infiltrating cells like T cells and macrophages will also change as well after a treatment. And we like to think that SAbR-like treatments can be almost like a immunological vaccine, that is, to cause a systematic response against the tumor that was otherwise masquerading and hiding from the immune system. And all of these things take time to occur. And if you get all the treatment done at once, you may not have time to exploit this effect. So we've decided that we're going to move in a direction at UT Southwestern toward a treatment that we're calling PULSAR. It's personalized ultrafractionated stereotactic ablative radiotherapy, where instead of using fractions, we're going to use pulses, and the pulses will be single treatments using SAbR. These larger dose, more potent treatments will avoid historical tumor control penalties for a split course because of their incredible potency. And more than one pulse can be given, but they're isolated from each other in time, at least 7 days, but often weeks or months. So we might be seeing more like a drug therapy where you give cycles every month. And that split course is called ultrafractionated. And the ultrafractionated pulsar is more than just avoiding toxicity. It's also going to allow us personalization and optimization through the adaptive process. So, for example, we'll start with a test pulse, maybe a 10 to 20 grade treatment, and then just see what happens. We'll wait and later mine the changes that occur that would allow adaptation. And with all the artificial intelligence that's going on in the department, these features of the tumor and the microenvironment and the patient might be put into an algorithm that would reformulate a plan or adapt using that higher information. Then we would replan for the next pulse, now this time though informed by how things are going, not just a one-size-fits-all therapy. And we would repeat that till either we cure the patient or we realize that it's not going to work at all. So in summary about UT Southwestern and SAbR has become a mainstream therapy, and that was particularly true after this terrible COVID pandemic where people wanted to not spend too much time in a hospital facility. SAbR certainly competes with surgery, but it really doesn't have to. Surgery is an awesome therapy, and SAbR might help it become more awesome, for example, through preoperative treatments, followed by SAbR treatments in conjunction with drugs. UT Southwestern's role in the early and ongoing development of SAbR has been profound. We carried out most of the early prospective studies, as well as prospective studies in multiple diseases, cancer diseases. Certainly, we are one of the highest volume centers in the world, and trainees that come from UT Southwestern are often sought after because of their large SAbR experience. And SAbR has been a big deal, but Pulsar could be even bigger. And so we're excited about using all the new equipment in the department, such as the MR-Linacs, to carry out this Pulsar treatment.